Let's climb on in and finish off our chapter 9, articulations, joints. And so we finished up talking about tendon sheaths of the hand and wrist. And now we're going to start off talking about the classification of our synovial joints. Now, you remember synovial joints were a joint that contained a capsule, all right, and inside the capsule there was a cavity there, joint cavity, articular cavity, and that's where we're going to have our fluid, our synovial fluid there. Okay, so these types of joints they're considered to be diarthrotic, which are highly mobile joints, right, compared to the other ones. So we're going to show you how we classify them, all right, by movements. Okay, so we have uniaxial, biaxial, and multi-axial. Those are the three types when we're basing or classifying the joints by movement. So obviously you can pick apart from the title of these joints and figure out what that means. So with uniaxial, that means the bones are going to move in just one plane or axis. And notice how it says it will move in that plane. So if we're talking about the frontal or coronal plane, all right, the movement when it's uniaxial will be, okay, in that, throughout that plane or around one axis, you know, the X, Y, Z axis grid there. Biaxial, all right, obviously, again, we'll have movement in two planes or in two axes, like the X and Y axis. And then we'll have multi-axial joints. So you from there, you can probably figure out, all right, so many planes, many axes. All right, so when we talk about how with the structural classification, we're going to discuss now the joint surfaces. And as we go from the top list down to the bottom, you'll notice that they go from least mobile to the most mobile. So our plane joints and hinge joints are going to be the more mobile joints. And then we also, you can see that the ball and socket joints are going to be the most mobile. And excuse me, let me rephrase that. Okay, plane and hinge joints are going to be the least mobile. Ball and socket joints are going to be the most mobile. All right, so let's start off with what a plane joint is. And if you think about it from the description there, right, the surfaces of that joint are going to be flat. And so you'll see this is the least mobile, obviously, because we're starting at the top of our list here. Right, so you'll see it along either one plane. Okay, and normally when we're talking about a plane joint, we're not really going to be dealing with an axial movement. It's going to be in a plane-like movement. Hence, that's why we call it a plane joint. Then we have our hinge joint. We're pretty familiar with hinges. Think of it like a hinge on a door. Okay, and then our pivot joint. Right, this is where we're going to see. Right, one bone will have a rounded surface. Right, that will go actually into either another kind of concave structure or like a ligament ring. We see that in our glenohumeral joint and a shoulder joint. In this case, right, when we talk about the pivot joint, a better example would be the radial, the humeral radial joint there between the head of the radius and the capitulum of the humerus. That's a better pivot joint there because, well, we're actually going to go into a little bit more detail on that. So let me not waste your time because we'll see this in much more detail as we go through the different joints. Condylar joint, we saw that, all right, when we were dealing with the occipital condyles and the lateral masses on C1 and the base of your skull. Saddle joint, we see that in the thumb, okay? You'll have a convex and concave surfaces that are actually going to interlock with one another and resemble a saddle shape. That's biaxial also. And then, of course, our ball and socket, right? This one here is going to be in many planes or axes. This is the most mobile type of joint. And just like the name says, ball and socket, you'll have one bone will have a ball-like configuration, while the other joint or bone will have that socket-like configuration. So when we're talking about the different types of motion, all right, gliding motion is going to be one of the simplest. And so we'll have two opposing surfaces, right, usually flat, that are going to rub past one another. All right, so we're not going to see a lot of movement in these types of joints. So this is a very common type of movement that you'll see in your wrist with the carpal bones and in the tarsals, right, in the foot. So we've seen the carpal bones, and those are short bones. And so a lot of those carpal bones, they're going to be as tall as they are wide, right? Not exactly, but for the most part. And so you'll have a lot of plane surfaces that are going to glide along one another. Right? It's tough to see this picture, but this picture, I like this figure, right? It shows all the different types of joints. I don't know why it's the text here is not showing up very well, but this is a good figure to take a peek at in your book to kind of get a better idea of what I'm talking about when I'm talking about these types of joints. So when we're talking about synovial joints, there's 4 types of motion that we're going to discuss. All right, I just talked about the gliding. All right, we're going to talk about angular, rotational, and then of course we have our special movements, everything else that don't fit into the first 3. All right, so again, the gliding joint is going to be, we'll have 2 opposing surfaces that are going to go back and forth or side to side. Not a lot of motion occurs here, and we'll see that in our carpals and our tarsals here. The angular motions are the ones that are more common that you may have heard. So we're going to deal with, right, the movement, right, that's going to occur in between 2 bones. So we're either going to increase this angle between the 2 bones or decrease the angles between the 2 bones of these joints. So you'll see all the different specific types here. We're going to march through each and every single one of them. So starting off with flexion, right, when we're dealing with flexion, we're going to see movement in the anterior posterior plane, or sometimes we'll call it the A to P plane. All right, so front to back. So perfect example, standing in the anatomical position, okay, bend your elbow. That's going to be flexion at the elbow joint. So that means you're going to bring your hand closer to your shoulder. Or for example, if I ask you, okay, can you grab your cup and take a drink out of it right now? As you're doing that, you are flexing your elbow joint. You are going to be bringing the bones in your forearm closer to the humerus. Extension is going to be opposite. We're going to increase, all right, the angle between the 2 bones or 3 bones, depending on what joints we're talking about here. Right. So again, it's still going to occur in that anterior posterior A to P plane, but now we're going to increase that angle. So after you've bent your elbow, now go ahead and straighten out your arm. Okay, return back to the anatomical position. Right, after you made a fist and you go to open up your fist to shake somebody's hand, you are extending, right? You're straightening your fingers, right, to shake that person's hand. So that's flexion and extension. And then you have hyperextension, which is an interesting term because a lot of times when we discuss it, you may have heard of somebody having a hyperextension injury. And that's when we extend, all right, the joint beyond its normal range of motion. And when you exceed the normal range of motion, there is a possibility that you can cause injury. All right, it's not 100%, but some of the examples when we go through here, those are going to be normal. But like when we're discussing other joints, like hinge joints like your elbow or your knee, that's the one that most people will complain about having a hyperextension injury. Okay, your knee straightens all the way out, usually to 180 degrees. But in that type of injury, you've gone past 180 degrees. Let's say you go to 185 or hopefully not to 190, but you can actually cause damage to the articular capsule and some of the ligaments there. And so it could be an injury. But when we're talking about angular motion, hyperextension is when we extend the joint more than 180 degrees. So when you're standing there looking up at the ceiling, all right, if you're in a museum and you're looking at the nice architecture inside and you're constantly staring up at the ceiling, that's what your neck is doing, okay, while looking up at the ceiling. That's hyperextension. Lateral flexion, right? Lateral flexion is usually typically discussed when we're talking about the trunk, but also the same thing applies to the head, okay? But this is what happens when you are moving within the coronal plane. Remember, the coronal plane is the frontal plane. So basically me saying to you, all right, standing there with your hands to your sides, all right, I want you to lean to the right as far as you can. And as you lean to the right, your lumbar spine is moving in lateral flexion to the right. So we call that right lateral flexion. Same thing if I ask you to lean your head to one side or the other. If I say to you, okay, look straight ahead. Now I want you to take your left ear and bring it as close to your left shoulder as possible. So as you start to bend your head to the left, you start to approximate your ear towards your shoulder, you are doing left lateral flexion in the cervical spine. So let's look at some of the pictures of some of these things. All right, so you can see here in the front, all right, when we're talking about, all right, the flexion and extension, so you're looking straight ahead. I tell you, okay, look down towards the floor, you bring your chin to your chest, that's flexion of the cervical spine. Then I say, okay, go ahead and look straight ahead again. Then when you go to bring your head back up to that neutral position, you are now extending the cervical spine. Then if I say to you, go ahead and look up towards the ceiling, right? And you look up towards the ceiling, you are now entering into hyperextension. Okay, so flexion extension, we saw that with the elbow. I already went through those examples. Same thing applies to the wrist, okay? When you are flexing the wrist, bringing your fingers close to the wrist or your elbow in the front, okay? That's gonna be flexion. Bring it as far back as possible, it's gonna be hyperextension. Bending your knee, okay, is flexion, straightening it back out is extension. And then we can see here with lateral flexion, right and left. All right, so we have some other terms here called abduction and adduction. I think of abduction, when you're abducting somebody like a kidnapper, okay, you're taking them away from their family. When we're talking about abduction for angular motion, that means you're going to be moving in a lateral movement away from your body's midline, basically away from your spine, okay, the axial skeleton there. So that's going to be abduction. So if your hands are down to your side and I said, okay, now bring your arms out away from your body so your body looks like the letter T, okay, that is abduction of the arm away from the midline of the body. Now, if I say, all right, you're in that T position, your arms are straight out away from your body as far as they can be, and I say, okay, go ahead and bring your arms back down to your sides. That is adduction, adduction. So that means you're going to be moving that body part towards the midline. That's medial movement towards the midline. And think about it, when you add something to something else, okay, you are going to move it essentially closer. If I'm going to add flour to water, I'm dumping the flour into the water. So if I'm adding my arm back to my body, I'm going to bring it closer to the midline there. That's adduction. So here you can see the examples. All right, abduction, this lady's lifting her arm away, moving it away from the midline of the body. Okay, and then she returns it back to that position against her side. That's adduction. Now, when we're doing it for the wrist, you can see in the anatomical position, if you move your wrist towards your thumb sign, that's abduction because you're moving it away from your body's midline. If you start to flex your wrist or bend it to the side there toward your pinky, that's adduction. You're moving it towards the midline. Now, when we're talking about fingers, spreading out the fingers, the midline in this case is going to be the middle finger, okay? So when you say, please abduct your fingers, just spread them open, you're bringing them away from the midline here, which is the third finger. And then when you bring them all close and approximate them to the third finger, that is adduction. All right, how about circumduction? This is when you are essentially making a cone-like shape with the movement that you are producing. And the proximal end, that's going to be the end that's closest there, all right, to the midline usually, or the more stationary area there. So when we're talking about circumduction, like in gym class, you may have been asked by one of your coaches or teachers in PE to do arm circles. So when you're doing arm circles, the head of the humerus, right, stays right there at the glenohumeral joint, and it doesn't move very much, but your fingers and hands do. And so they make this nice cone configuration here. Same thing here when we're talking about circumduction with your hip. Okay, so the proximal end then stays relatively stationary, whereas the distal end is going to be making more motion and movement. All right, so that is circumduction. And then we have rotational motion. All right, so when we're rotating something, we're always going to be rotating, all right, that bone along its longitudinal axis. So we have a couple different terms here: lateral and medial rotation, and pronation and supination. Okay, so let's start with the lateral rotation. First, you need to make note that when we're discussing lateral and medial rotation, we're always going to use as a reference point the anterior surface of whatever bone that we're going to be moving. And I'll show you through some of these examples here. Okay, so when we move the anterior surface of a bone laterally, we call that lateral rotation. And if we are going to turn that anterior surface of the bone, all right, medially, we call that medial rotation. So remember, the anterior surface is our reference point. So when we talk about pronation and supination, this is going to be solely in reference to your forearm, okay? So our reference point is now going to be the palm of the hand. So pronation, the palm is posterior, easy to remember, pronate, palm, posterior. As we do that, right, we are going to move that forearm into medial rotation. And then supination, like you're going to hold a bowl of soup, so your palm of your hand is going to be anterior. So supination, the palm is going to be anterior, so that is going to cause a lateral rotation. I'll show you these right here. Okay, so here we're looking at Linda Blair from The Exorcist. She's swinging her head back and forth. That's actually not Linda Blair. Okay, but when we're talking about rotation in the cervical spine, okay, if I want you to turn your head to the right, that would be right rotation. And then if I ask you to turn your head to the left, that would be left rotation. Okay. So when we're dealing with lateral and medial rotation, we're going to remember, use the anterior surface, all right, of whatever bone that we're moving. So that would be the bicep here for the humerus is going to be our anterior surface. So you notice that for lateral rotation, that bicep is going to now be facing laterally. And then when we go into medial rotation, all right, the anterior surface of the bicep has now gone medially. So it's always going to be, all right, wherever that anterior surface of whatever bone that we're discussing. So when we're talking about here in the hip, right, the anterior surface will be either the thigh or the shin. Okay, so if you rotate it laterally, all right, then the thigh and the shin will be facing to the lateral side. Same thing, and so your toes will be pointing out. So if we turn our toes in, okay, our thigh and shin will point inward or medially, and that's medial rotation. You notice here, when we're talking about pronation and supination in our forearms, remember, pronate, palms posterior. So the palms are facing posteriorly. And so that is going to cause that medial rotation. And then when we're talking about the supination, right, the supination, right, our palm is going is anterior, facing forward. And so we'll get that lateral rotation going on. All right, let's talk about those special movements, because remember, those are all the other ones that are left over. They don't really fit in any of those other categories. So we've got depression and elevation. Now, a lot of these folks, you'll figure it out just by the name, the term there. All right, depressing. So if I were to say, please describe to me depression of the mandible, you would say when you open your mouth. Okay, so we're talking about the mandible, which is the only mobile bone in your skull. Okay, it drops down. That will be depression, inferior movement of the mandible. So when I say, please describe to me elevation of the mandible, you'll say, when you close your mouth, okay, when you approximate your teeth, when you clench your jaw. Okay, now we're going to see superior movement of the mandible. Okay. We can also apply depression and elevation to your shoulders, your scapula, whatever you want to use as a reference point. All right, when you elevate your shoulders, like when you're shrugging, like, all right, who ate the last cookie? I don't know. I don't know. You're elevating your shoulders, right? You're bringing your shoulders up towards your ears. That's elevation. All right, and then when you're sad and depressed, you know, because your parents are making you go to bed early when you were a little kid, all right, or you find out that you've lost the internet at home, okay, your shoulders drop down because you're depressed, right? And they go down towards the floor inferiorly. That's depression and elevation. Dorsiflexion and plantar flexion are two movements that are to the ankle joint. We don't describe them anywhere else. And so when we talk about the ankle joint, the actual name for it is the talocrural joint. And so when we're referring to our reference point for the movement at the ankle joint, we're talking about the top of your foot or the dorsum of your foot. So when you start to bring the dorsum or the top part of your foot towards your shin, okay, looks like you're digging your heels in, that's dorsiflexion. So you lift your toes up towards the ceiling, you start to bend your toes and move your toes towards your shin or up towards the ceiling, that's dorsiflexion. Plantar flexion is the opposite. All right, now what you're going to do is you're going to point the dorsum down. Okay, like when I ask you to please get up onto your tiptoes. Okay, so you are now planting the balls of your feet, all right, which is the heads of the metatarsals on the ground. And that's like a ballerina. When they go into that toe-like position, they're going into plantar flexion. Basketball players do it all the time when they go into a layup or any type of jump. They go into plantar flexion. All right, then we have eversion and inversion. In that case, we're going to refer to the sole, the bottom of your foot is our reference point. So when you're going to, when I say to you, hey, evert your foot, that means I want you to turn your sole outward. That's a tough one to do. It's harder to evert your foot than to invert your foot. All right, so when we do inversion, we're going to turn your sole inward medially. Okay, so you can see. So when we turn the sole laterally, that's eversion. When we turn the sole in medially, that's inversion. That's the most common way to sprain your ankles, an inversion ankle sprain. That's usually the first thing that the orthopedic or your doctor should ask you, a sports medicine person. They should say, hey, all right, what was your foot doing when you hurt it? And then most of the times they'll say, I had it in this position here. Protraction, retraction, again, we can limit that to our jaw. Okay, so when we ask you to protrude or protract your jaw, we're going to move your jaw forward, away from the anatomic position. All right, retraction, we ask you to pull your jaw or your mandible, excuse me, in. Okay, so your top teeth are hanging over your bottom teeth. Okay, so that's retraction, pull the jaw in. When I was a freshman at the Citadel, which is called, there's a name for freshmen at the Citadel, they call them knobs. And when I was there, it was all male, and they said knobs because it looked like, because they shaved your head, and so it made you look like a doorknob. Anyways, you had to assume this position, they called it the brace. And so when you're standing there, it's almost like you're in the anatomical position, except you have to bring your hands directly against your side. You have to roll your shoulders back as far as you can, basically trying to pinch your shoulder blades. So you're doing that, right? You're looking straight ahead. And when you're looking straight ahead, you're going to pull the back of your head as far back as you can. While you're doing that, you're going to retract your chin. You pull your chin in. That's what they used to always say to us. Pull your chin in, knob. And you had to pull your chin back and retract it back as far as you can. All right, opposition and reposition. This position here of the hand, for anybody that has had anything to do with Boy Scouts, this is the when you make the Boy Scout oath, this is the configuration for your hand that they ask you to assume. Well, that's actually going to be opposition, when you are going to take your thumb and approximate it towards your pinky. Then you have reposition, and that's going to be when you move your thumb back to its original position. All right, so that's it for the movements there. Hopefully you have at least a little bit of a better understanding. What I would do is look at the pictures to kind of help along with that. So now what I want to do for the remainder part of this class is go through some of the joints. Some of these joints you'll find interesting, some maybe not so much, okay? But we'll try to add a little bit of flair. So let's start off with the temporalmandibular joint, the one that we always fondly call TMJ. Oh, I have TMJ. Well, I have one too. In fact, I have one on the left and one on the right. But usually when you hear people complaining of TMJ, they're talking about jaw pain, which we'll talk about here in a moment. So the temporalmandibular joint, this is going to be, and I said it before, the only mobile joint in the skull. And so what we see is, this joint has a capsule, right? And so inside this capsule, what I haven't mentioned before is we have a disc there made of fibrocartilage. How nice is that? And so the fact that the disc is approximated between the two bones there, right, the temporal bone and your mandible, right, the fact that that disc is there, when we surround that disc and those bones by this capsule, we've effectively created two separate synovial cavities. I think I got a picture here. I'll show it to you. There it is. Right here are our two separate synovial cavities, and that's what we've done. Okay. You got the mandible here. Okay. And then you can see here, you've got our disc, and then we've got our temporal bone here, the mandibular fossa, right, which has the disc, and are two separate synovial cavities there. It's kind of neat. So two of the ligaments that you should be a little bit familiar with are the sphenomandibular ligament and the temporalmandibular. Now, a lot of times, right, when we're dealing with anatomists with these ligaments, they pretty much name the ligament with some of these bones, right, to which they attach to. So sphenomandibular, right, we are going to see this ligament attached from the sphenoid bone, right, onto the mandible. All right, the temporalmandibular, this joint will attach on from the temporal bone and onto the mandible, right, and this is going to actually help support the mandible. All right, so when we're dealing with the movements of the mandible, primarily it's going to be that hinge joint. Simple. Open your mouth, close your mouth, okay? Depression, elevation, okay? But we'll also see some gliding going on because, you know, when you're chewing stuff with your molars, you're going to grind it down, okay? But to help grind it, you need some side-to-side movement there. So we'll get some nice side-to-side grinding going on. And then we'll also have, all right, some pivot movements also. So we saw what we at the joint there. It's not just simple depression elevation movements. We get some protraction, retraction going on, and some lateral side-to-side movement for grinding. So that brings me into TMJ, okay, our temporal mandibular disorder here. All right. So for pain while opening mouth, with popping and pain, with pressure for chewing with TMJ, would you see it? Ooh, those are very good. That's a very, very good question. And to be honest with you, I actually had a conversation with a dentist about that once. And basically, first of all, I would, if you were going to go see, I would start off with the dentist because that's their job. All right. They know these joints in and out, especially right when they want to deal with the temporal mandibular joint. And some dentists will promote themselves for temporal mandibular disorders. And that's where I would start. I know some dentists hate TMJ. And so they'll make referrals out. Yeah, I hear you. Okay, that's interesting. And that's a good possibility. You know, when that happens, and to be honest with you, there's no guarantee that surgery will even correct it, depending on, again, I'm guessing, I know nothing about his case, but depending on the correction for temporal mandibular disorders. I'm not a huge fan. I've tried to treat some. I've had some success, and sometimes I haven't had success. And so I would always just start off with the dentist and see, especially if they do specialize in temporal mandibular disorders. But in some cases, I mean, if this case here, if he's having pain while he's eating, that's something that probably needs to be taken care of, all right, or addressed, because there's ways. Sometimes TMJ disorders can start from grinding at night. If you're under a lot of stress, people with bruxism, they'll start to grind in the middle of the night. For whatever reason, that pressure there can cause some issues with the jaw. It could be, you know, in some situations, and again, depends on what medical professional you're talking to. If he's either a dentist or a doctor that specializes in TMJ, they might say, here, start off with a night guard. So there's a lot of possibilities with that. So here, when we're talking about most TMJ disorders, we're going to be dealing with the ligaments. Something's happened to the ligaments. And so because of that, as you know, the ligaments help to add security and stability to joints. So now, if there's an issue with the ligaments, or maybe they got overstretched for whatever reason or damaged, right now that joint is not going to be as secure and it won't have the stability. So now you can start to get some disc subluxation, which means the disc can move out of its normal position. When that happens, usually that's when the clicking and the popping occurs. And so a lot of people will start off with pain, and right in that area, right over that joint. And in some cases, they'll get it in other areas. They might have earaches from it. The eyes could hurt. Now, this is getting crazy. Normally, you'll see it right over the joint. People will complain of clicking and popping. All right. Smaller numbers will complain of eardrum pain, all right, or even mouth or eye pain. All right, shoulder joint, one of my favorite joints. I have a lot of favorite joints, okay? But when we're dealing with the shoulder joint, we have to consider that there's a couple different joints that in our shoulder joint, if that makes sense. Okay, we have the sternoclavicular joint, we have the acromioclavicular joint, and then you have the glenohumeral joint. That's the most commonly referred to joint for the shoulder joint, would be the glenohumeral joint. All right, but our sternoclavicular joint and our acromioclavicular joint are still part of the shoulder complex. So that's why we're going to talk about them here. So our sternoclavicular joint, that's the joint that where the collarbone, the clavicle, right, articulates with the manubrium on the sternum. And so it actually makes a saddle joint. So of course, we're going to have an articular disc in this again, because it helps, right, with cushioning there. Because remember, I don't know if you recall, but the only bony articulation of your upper extremity to your axial skeleton is at this joint. Right? The scapula doesn't have an actual bony articulation directly to the axial skeleton. The scapula just kind of floats there on the back of your thoracic cage behind some muscles. It's embedded with muscles surrounding it. Okay, so in this joint, all right, you have another articular disc that again is going to separate and create two synovial cavities. So we'll see elevation and depression makes sense as you raise and lower your arm. You'll get circumduction there too. All right, not a lot, because most of that, when you're doing circumduction in the upper extremity, most of that will be at the glenohumeral joint. All right, so of course, we're going to have in this sternoclavicular joint, it's going to be surrounded by a capsule. And so it's going to have ligaments within that capsule. So this joint here, it's a tough joint to dislocate, right? Because of one, a bunch of the muscles that are around that area, but because of also, all right, the ligaments and capsules here. So when we're talking about those types of joints, keep in mind, if I say that it's tough to get dislocated, most cases, all right, it's going to have a pretty decent amount of ligaments that add to the stability of the articular capsule there. In addition to muscles too, because you know that muscles and the tendons of those muscles help to add stability to joints. So our acromioclavicular joint, also known as the AC joint, this is where the other end, the acromial end, all right, of the clavicle articulates with your scapula. And so this is a plane joint. And we've said this before, at plane joints, right, we don't get a lot of movement there. So again, in this joint, we see another disc. Now, it's important that you know the deals with these two ligaments here that I'm going to talk to you about, okay? All right, we have the acromioclavicular ligament and the corticoclavicular ligament. All right, these ligaments here are going to help to maintain, all right, that the alignment of the clavicle onto the scapula there. And so what we'll really see a lot too, when we're dealing with damage to either one of these ligaments, right, we will see what we call a shoulder separation. I'll talk about that in a second here. All right, so these two ligaments, right, is going to be crucial for proper acromioclavicular alignment there. And then finally, we have our glenohumeral joint, our true shoulder joint, I should say, and that's a ball and socket. And ball and sockets, we talked about that, can move through many, many axes, many, many planes, right? It's the most mobile type. And so the head of the humerus, that rounded edge there, is going to articulate within the glenoid cavity there of the scapula or the glenoid fossa. And so that's where we're going to see a lot of movement. In fact, this is the joint, I've said it before, that has the most amount of range of motion. Therefore, it's the most unstable. And if it's unstable, it has a high likelihood of dislocation. So what we've tried to do to make that joint a little bit more stable is that we've taken some fibrocartilage and we've lined the outer portion of the glenoid cavity. And so we call that the glenoid labrum. It's this little lip, okay, but it's made of fibrocartilage, and it helps to make that ball and socket joint a little bit deeper. And then, because there's so much movement there, we put in a lot of bursa because they help to reduce friction, because we have tons of muscles around that area. Our rotator cuff muscles are going to add stability to the joint, but they're also going to help to move the joint. And then we have a whole bunch of other muscles, which we'll talk about when we do chapter 11 for muscles, but we have a whole bunch of other muscles that help to move around your upper extremity. So we have a couple ligaments and tendons that are going to be located in this joint. Okay, your coracoacromial ligament, the coracohumeral ligament, and the glenohumeral ligaments, all of those are going to help to add stability to this joint. And in addition to that, okay, the long head of the biceps brachii will also be found in this joint. And I say that only because it's not uncommon for people to strain their biceps brachii muscle. And if they damage, all right, the tendons, and if it's the long head, it will have pain in that shoulder joint. And that could be the etiology or the cause to the complaint there. Okay, so I said it before, all right, this is the most mobile joint, but it's also the most unstable joint. So we've made some alterations to the joint to help it make it more stable. We added that glenoid labrum there to make the cut part a little bit deeper, but also now we're going to take some muscles, okay, because I've said that muscles can offer stability to joints. So we've taken 4 muscles, which we've called our rotator cuff muscles, and these will give the glenohumeral joint the much needed stability. Okay, it helps. It's not going to stop all dislocations, but primarily, all right, the stability of this joint relies on these 4 muscles: subscapularis, supraspinatus, infraspinatus, and teres minor. Right. So there is a mnemonic, not a mnemonic, but I'm having a problem remembering. All right, an acronym. All right, SITS, the SITS muscle. Rotator cuff is the SITS muscle. The first S is subscapularis. No, actually, the first S is, doesn't really matter. You can either be subscapularis or supraspinatus, but I make it supraspinatus because the second letter stands for infraspinatus. So supraspinatus, infraspinatus, teres minor, and subscapularis when I'm talking about the SITS muscle. Okay, and their job is to keep that humerus, the head of the humerus, in the glenoid cavity. So here you can see, all right, the glenoid, hold on one second, the glenohumeral joint here, okay? You can't see the head of the humerus, but it's approximating now into that glenoid cavity there. And then we have here some ligaments that help stabilize the clavicle and align the clavicle with the acromion. Okay, we talked about the coracoclavicular ligament and the coracoacromial ligament. If you damage these ligaments, you'll see that the clavicle will jump upwards. And so you'll have a drop off here at the AC joint there. All right, you can see now when we're talking about flexion of the glenohumeral joint, we're moving through the anterior posterior plane here. So flexion, we're bringing the palm of our hand closer to our to the front, and then an extension, we're moving our hand away from our front. Okay, so a lot of these ligaments here are going to fuse and help to add to the stability of our capsule there, the glenohumeral capsule. So now we've cut away and we're looking at the inside of the joint here. All right, here's the labrum. Okay, it makes that cup a little bit deeper. So when the head of the humerus sits right in there, it makes it more difficult for it to pop out. So you can see here's the actual glenoid fossa, and then the glenoid labrum here above and below makes it a little bit deeper. So this can kind of hang out in there a little bit more. And then we have our SITS muscles, the rotator cuff muscles, that are going to be in close approximation, and their job is to help hold, all right, the head of the humerus into the glenoid cavity there. All right, so when we're talking about, all right, dislocations to our shoulder, like shoulder separation, we are referring to the acromioclavicular joints. And so a lot of times you're going to see, right, when you're in abduction, that is when things can go wrong. So that position is usually, all right, the position in which when folks suffer an injury like a shoulder separation or a shoulder dislocation, somehow their arm was in an abducted position. In this case, when we're talking about shoulder separation, it's abducted more than 90 degrees. Okay, and then we'll see if we damage, all right, those ligaments that I was telling you about, all right, the acromial ligament and the coracoclavicular ligament, if we damage those, then that will cause the alignment for the clavicle and the acromion to be off. Now, when we're talking about a dislocation, that's when we're talking about the glenohumeral joint. That's when the head or the humerus, all right, gets knocked out of that cup. Right? Again, usually happens when we're in the abducted position. And when that occurs, most of the time, we'll find the head of the humerus in front and below the glenohumeral joint. Okay, so usually one of the ways that they help to reset that is have the person lay down on their back. Okay, you grab on to their hand and you put your foot in their armpit. And then as you kind of pull, you got to do it fast. I'm not telling you exactly how to do it, but this is one of the techniques. You're going to distract the head of the humerus out a little bit and push up with your foot, and you can pop the head of the humerus back into the joint. All right, elbow joint. This is a hinge joint. And so this type of joint, this hinge joint, has two articulations. Because remember, you have two bones in your forearm. So you'll have the humeral ulnar joint, and that's going to involve, all right, remember the trochlea, and the trochlea was on the humerus, and the trochlear notch, all right, was on the ulna. So we're going to have the trochlear notch of the ulna. It's going to articulate with the trochlea of the humerus. Then you have your humeral radial joint, in which the capitulum of the humerus is going to articulate with the head of the radius. And the cool part is that both of these joints have one capsule that surrounds them. All right. So you'll have two joints, all right, in one capsule. And so all these, again, I'm not expecting you, just be familiar with these ligaments, okay? But you'll see the ones that I want you to be familiar with is this fella here, the annular ligament. That's an important one. We'll talk about that in a second. Okay. Here you can see it, all right, from the medial side. So again, you have, let me go back here. Well, you can't see it, the inside of the joint, but here is the trochlea, all right, and then you have your trochlear notch right down here that's approximating with the trochlea. And because of that bony configuration there, it's very difficult to dislocate that joint. So the nice thing about it, because of, yes, the type of movement that occurs here, it's a hinge joint, so it doesn't have a lot of mobility, all right, it has a decent amount, so it's going to have a lot of stability. And what adds to that stability is not only the configuration of the joint, but also, all right, the fact that the articular capsule is pretty thick. And so we have a bunch of these ligaments here that help with that, all right? We have the radial collateral ligament, the ulnar collateral ligament, and then the annular ligament. So the radial and ulnar collateral ligaments are going to be these ligaments that we find on the side here. So we're looking at it from the medial side, because the medial side is going to be where the ulna is. You have your ulnar collateral ligaments. And then when we see it from the medial side, you're going to have the the radial collateral ligament here. And so they add a lot of stability. And so you'll see that some of these ligaments will help to add stability to that joint capsule there. All right, one of my favorites is going to be the annular ligament. This goes around, all right, the head of the radius, okay, and it attaches onto the neck. And so what we'll see here is this is going to bind the head of the radius to the ulna, and that's going to help us to prevent, all right, subluxations. Except in this scenario, because this happened to my brother and my niece when she was really young, 5, I want to say. All right. So what happened was he was holding my niece's hand, and they're walking along, and she stumbled. She couldn't have been 5. She had to be younger than that, 3 or 4. Well, anyways, she stumbled, and he held her hand. And because of that, what had happened was the head of the radius popped right out of the ulnar ligament. And I want to say, I don't think I have a picture of the ulnar ligament very well. You can see it a little bit over here. Okay, so here's the head of the radius, and you have this ligament that just wraps around it. And so when he dislocated the radius, he literally pulled the head, all right, of the radius out away from the annular ligament there. Yes, you beat me to the punch, Christina. Nice going. And I say that not as sarcastically. Nice going. Good job. Yes, that is called nursemaid's elbow. Yep. And it is common in small children. You're absolutely right. So, all right. I'm glad to see that somebody out there has heard of this before and doesn't think that I'm making it up. No, I'm kidding. But what we'll see is, all right, because kids, all right, haven't had those fully developed tissues yet, that ligament is thin. And so it just slides right out of there. And basically, to pop it back in, right, you just shake hands with the person. And as you're doing it, you kind of push, you hold on to the back of their elbow, have their elbow bent, right, close to 90 degrees. You shake hands, and you just kind of twist their hand, torque it back and forth a little bit while pushing it back against the elbow. And usually it'll pop right back in. Yeah, pretty cool. Okay, so now let's move down into the lower extremity, and we are going to discuss the hip joint. All right, so and I don't know if I mentioned it to your section, but I have mentioned it before in the past. The hip joint, most times people will often confuse when they say the hip joint. They'll either be talking about the femoral acetabular joint, is where the head of the femur articulates with the os coxa, or the sacral iliac joints. So often they'll confuse those with the hip joint. But when we're talking about the hip joint, we are talking about the femoral acetabular joint, where the head of the femur articulates into the acetabulum of the os coxa there. And so we're going to see, all right, a similar phenomena in the hip joint on the os coxa that we saw on the scapula in the glenoid cavity there. We're going to have an acetabular labrum. So now we're going to try to deepen that socket there, so to make it, all right, much more stable. Because again, this is a ball and socket joint. There's a decent amount of movement in this joint. And so therefore it's going to sacrifice stability. But in this particular joint, it won't be as mobile as the glenohumeral joint. So it is more stable. And part of that stability is with the acetabular labrum. And if you look here, look at all of these ligaments here, part of the capsule. Tons, they're all over the place. Okay, so all these ligaments are going to contribute to the mobility, or excuse me, the stability, therefore indirectly to the mobility of the joint. And so you're now seeing here in our little skeleton fella here, all right, flexion of the hip is bringing your knee forward, and then extension of the hip is bringing your foot back. Then you can see with abduction, bringing your feet away from the midline and then bring your leg back down, right, to stand on it. That's adduction. And you can also see here in the internal portion of the joint, you do have a joint space here. And then we talked about it last class, how you have that little indentation on the head of the femur, and that's called the fovea. And that's where a ligament will attach, right, onto the head of the femur and into the acetabulum there. Okay. So the ligament of the head of the femur, it doesn't really add much stability, if anything, to this joint. Okay, but it does attach. Okay, and you'll actually find a blood vessel in there. We'll talk about that in a second. All right, so when we're talking about the support of the hip joint, okay, primarily it's going to have that stability is gained from the articular capsule. And then we'll make it even stronger. We'll surround that and have some extra ligaments there. And if that wasn't enough for you, now we're going to just throw a whole bunch of muscles in that area there and make that joint much more secured. It's much more difficult to dislocate a hip than it is to dislocate your shoulder, right, in normal experiences there. All right, so again, the articular capsule is going to extend from the acetabulum of the os coxa all the way to the lesser and greater trochanters on your femur. So essentially, it's going to surround, right, the femoral head and the entirety of the femoral neck. You won't see that. And we have these special fibers, all right, called the retinacular fibers. And these fibers, okay, come off of the articular capsule, and then they kind of bend back and reflect around the neck of the femur there. And what's important about these fibers is we have blood vessels in here. And so if those fibers get damaged, it can damage the blood vessels, and you can get avascular necrosis to the femoral head and to the neck. And that's a problem, because if you get avascular necrosis, that tissue death, then you can damage those the bone, right, quite extensively there. You may be asking for a hip replacement, and that would suck. But they've come so much further nowadays than they have before. All right, then we'll have our intracapsular ligaments. These are those 3 ligaments here that are going to add, all right, stability to the joint. The iliofemoral ligament is going to be found, this is important, you should know this, on the front of the articular capsule. The ischiofemoral ligament is going to be behind it, posteriorly, and then the pubofemoral ligament is going to be on the inferior portion there. So if you notice, we don't really have anything superior. Not to worry, okay, because you have tons of muscles that sit up above there. Right, so all these ligaments will become taut and tight when you extend the hip backwards. And then you have I've already mentioned this about the head, the ligament at the head of the femur, ligamentum teres there. Again, it does not add any stability or strength whatsoever, right? But it does contain an artery that will supply, right, the head of the femur. Unfortunately, if you do damage that ligament, there's a good chance you could damage the artery. And again, you can have avascular necrosis, and that's bad. That's not good. We don't like that. All right, let's move on down the lower extremity to our knee joints. Okay, this is a cool joint. It is the largest joint. Okay, so therefore, of course, since it's the largest, we're going to make it the most complex type of diarthroses. Remember, diarthroses are the most movable type of joint. All right, so primarily, yes, it works as a hinge joint. So you're going to get flexion and extension there. But what a lot of people don't realize is we'll see some rotation in there, and we'll get a little bit of lateral gliding, right, when you flex. Now, you'll get some rotation in the extended position, but if you really want to visibly able to detect it and see it, if you bend your knee, all right, you can actually externally rotate your feet, all right, in and out, or internally rotate them, or medial or lateral rotate, and you'll see some rotation going on. And it's almost like a corkscrew-like motion that occurs in the joint, right? But usually you'll see it much easier when it's flexed, because when you have it in the extended position, you lock the joint somewhat. Right, so when we're dealing with the actual knee joint, we have 2 separate articulations. Okay, we have the articulation between, because remember, okay, your knee joint is going to be a joint in which you have the femur, the one bone from the thigh, articulate with 2 of the bones in the leg. All right, that's going to be the tibia and the fibula. Okay, but here, when we're dealing with our knee joint, right, we're also going to see the tibial femoral joint that is going to be primarily most people talk about the knee joint. This is the joint that they're talking about. Right, this occurs between the 2 condyles, the medial and lateral condyles of the femur, and it'll articulate with the condyles of the tibia. We haven't talked about those yet. And then we can't forget about our sesamoid bone, right, the patella. All right, then you're going to see the other joint articulation occur between the patella and the femur. So here you can see, now again, what you see on this picture is just a bunch of ligaments. I'll show you which ones that I really want you to pay close attention to. Okay, so here you can see the quadriceps tendon. And then here from the patella down to the tibia, this part of the tissue, because we're going from one bone to another, we call that the patellar ligament. But actually the patellar ligament is part of the quadriceps tendon. Then we have a ligament on the actual outside of the lateral portion of your leg. And then we have another ligament on the inside, all right, the medial portion of your leg. And then we're on the back here, you'll see a whole bunch. We'll go through some of these, okay? All right, so notice we bent the knee. We're looking at the knee from the inside, and you'll see these 2 important ligaments in the intercondylar fossa here. Okay, you have one, okay, here that's going to be more in the back, so therefore we call it the posterior cruciate ligament, and then the one that's closer to the front is the anterior cruciate ligament. So you may have heard of these as the ACL and the PCL, and they provide they actually prevent the knee from sliding, back and forth on one another. So when we're looking at it from the posterior view, you can see the posterior cruciate ligament nicely. So on the lateral part here of our joints, you have this ligament called the fibular collateral ligament, right? I don't really call it that. More often than not, I call it the lateral collateral ligament because it's on the lateral portion, okay? But we're going to go with what the textbook, there's several different names, okay? But more people in sports medicine are used to calling it the lateral collateral ligament and the medial collateral ligament for the medial portion. So you'll see here, we have our fibular collateral ligament on the lateral portion. And then here on the inside, okay, we'll have the tibial collateral ligament. And that keeps the knee from abducting or adducting too much. And then you can see our menisci, okay, those fibrocartilaginous, all right, compression discs, okay? Here's the medial meniscus and here's the lateral meniscus. And they act as shock absorbers for compression. So when we're dealing with our knee joint, again, it's another capsule joint. And so you'll have a capsule that encloses, all right, the lateral and medial portions in the back of the knee, but we don't really see it in the front, okay? And that's because we've got our quadriceps femoris tendon in the front there. So we're okay with that. And we also have the patella. So you have your articular capsule that surrounds the medial and lateral and posterior parts of the knee. Then we have our quadriceps femoris tendon, which is going to be in the anterior surface, which is where we'll find the patella. Then the inferior portion of the patella, all right, that attaches to the tibial tuberosity, we call that the patellar ligament. And then we're going to have our fibular collateral ligament, which is going to be this guy right here on the lateral portion. It's going to attach from the head of the fibula here onto the lateral portion of the femur there, okay? And this, again, will help us from causing what we call hyperadduction. Okay, that's going to be kind of like a excessive bow-leggedness. Then we have our tibial collateral ligament, also known as the medial collateral ligament. And so this is going to extend from the tibia onto the femur. That prevents hyperabduction, okay, bending your foot out away from your midline. Our medial and lateral menisci, we already talked about that. That's our nice fibrocartilage, shock-absorbing pad there found on the tibial condyles, right below, right, the medial and lateral condyles from the femur. And then to make sure that the knee doesn't slide, all right, too far forward or too far back, we have our cruciate ligaments. Okay, so they cross over inside. And so we have the anterior cruciate ligament, right? That's going to prevent hyperextension and any type of anterior displacement of the tibia. And the posterior cruciate ligament, obviously, that's going to be more in the back portion, right? And that's going to prevent hyperflexion and also any posterior displacement of the tibia on the fibula, on the femur, excuse me. All right, so of course, I can't not talk about this joint and not talk about all the injuries that go on. And you may, if any of you follow sports or just in general, okay, you may have heard of some of these types of injuries here. All right, so what we'll see is, all right, if you are wrestling somebody and they start to yank on your leg, okay, and they're trying to pull your foot, right, away from your midline of your body, basically bend your knee inwards, okay, they can damage that tibial collateral ligament or that medial collateral ligament. And so when the leg is being abducted forcibly, okay, like in wrestling, it can happen, okay, or in football, if you're in a tackle pile and someone lands on your knee, it pushes, all right, your femur inward and the top of your tibia inward, it'll cause abduction. Well, the same thing can happen if someone is pulling on your leg the other way. Okay, you can damage the fibular collateral ligament, also known as the lateral collateral. Okay, so when they start to press in on the medial side of the knee, so if you're playing football and someone, as you're running and someone strikes you there, then that can damage your lateral or fibular collateral ligament there. In situations when the leg, often seen, again in contact sports, when you've hyperextended the knee, most likely you are going to injure the anterior collateral. If you've had it flexed too much, then you will damage the posterior or the PCL, the posterior collateral ligament. So the meniscus, because they're fibrocartilage, right, it takes a lot for them to get damaged. So normal wear and tear is not really going to do it too much, right? But if we have some sort of trauma or excessive overuse, then you can damage the meniscus. So there's this condition, it's called the unhappy triad. I've seen it many, many times, right? This is a very common type of injury, especially when you're playing contact sports, i.e. football. Okay, the person is running down the field, they have the ball, and they get hit, all right, from the side. So they're running, and someone tackles them from the side and hits them on the lateral side of their knee. And what that will do is that will cause abduction. And we saw what happens during abduction. We'll see damage to this guy. Okay, so the lateral collateral, or excuse me, the medial collateral, tibial collateral ligament gets damaged. The medial meniscus also gets damaged, and the ACL gets damaged because we are getting some rotation that's going on. And so that can damage the meniscus, right? But the ACL, because of, all right, that hyperextension, can get damaged and torn. Now, one of the things that you can't really tell is when we're talking about the tibial collateral ligament, if you look here, the tibial collateral ligament is actually physically attached to the medial meniscus. And that's another reason why the medial meniscus becomes damaged. If you look over here, all right, our the fibular collateral ligament does not attach onto the lateral meniscus there. So that's why when we have this unhappy triad going on, right, if the if the tibial collateral ligament gets damaged, all right, that is usually going to cause damage to the medial meniscus. All right, one more joint, and that's the talocrural joint, right, otherwise known as the ankle joint. Another type of hinge joint. And we talked about the motions that occur there, dorsiflexion and plantar flexion. So we're going to see again, in this situation in your ankle joint, two articulations that are going to be found within one capsule. So one articulation occurs between the distal end of the tibia, that's the bigger bone in your leg, with the talus. And then the other one is going to be the distal end of the fibula, that's the smaller non-weight-bearing bone, right? That's on the lateral portion of your leg. And that also is going to articulate with the talus. So both the bones there in your leg articulate with the talus, which is that top dome-like bone here. You can see it right there, sort of. That makes up the ankle joint. So you can see here, hold on one second. This is a lateral view. So we'll see the fibula here on top of the tibia. And you'll have these three ligaments here, right, that make up the lateral ligament. All right, you got this little fella here, this little fella here, and this little fella here. Now, they each have their own individual names. I'm not going to have you worry about it, but it's these ligaments that get damaged when you sprain your ankle. Remember, I was telling you about the inversion and eversion ankle sprains, right? Usually, it's one of these two ligaments that get damaged, right, during that sprain there. So now you can see it from the medial side. If you look here, okay, you have what's called the deltoid ligament. And again, it's much smaller ligaments that make up this greater ligament, but the deltoid ligament, see how many ligamentous fibers you have attaching onto the tibia? And look, you don't have as many here. So that's another reason why you have a more common inversion ankle sprain than you have an eversion ankle sprain, is because of all those ligaments. So you have the deltoid ligament, right, that are usually going to be injured, and then you have your lateral ligament that is usually injured. All right, let's just finish up here and talk about development, how these joints develop, and then what happens when they age. So these joints will start to occur at the 6th week of development. Well, that's cool because, as you know, right around week 8 is when you start to undergo, right, your bone formation, ossification. And so what we'll see is when the cartilage model starts to break out, when your fetal skeleton is developing into that humanoid appearance, right, we're going to have, right, these bones start to approximate and get close to one another to form these joints. So when we're talking about the fibrous joints, the future fibrous joints, right, that comes from mesenchyme, because as you know, in fibrous joints, you are going to have dense connective tissue, and dense connective tissue comes from mesenchyme. So that mesenchyme is going to differentiate into that dense regular connective tissue that you're going to find in between the two bones. When we're talking about our future cartilaginous joints, same thing, because remember, cartilage is a connective tissue, and so it comes from mesenchyme. So this mesenchyme will differentiate either into fibrocartilage or hyaline cartilage. And then for our synovial joints, we'll see a couple things happen here, okay? The lateral mesenchyme is going to form the articular capsule in the supporting ligaments, so more of the exterior, all right, part of the joints, all right? The other layer, right, is going to be, or the next layer in is going to be, the mesenchyme is going to form the synovial membrane, that areolar connective tissue. And finally, all right, the mesenchyme at the center, right, that is going to either be completely resorbed and go away, and then we'll have a joint cavity there, or this is where we're going to see menisci formation and articular discs, which we saw in some of our other joints like the sternoclavicular joint, the temporalmandibular joint. We'll get those little discs that are going to form at the center of the joints there. So that's what happens as we start to develop. Now, what happens when we age? Let's fast forward to the end of life, right? We're going to start to get aging of joints. So you've heard this term before, arthritis, and there's different types of arthritis, right? We'll have the rheumatic, types of arthritis, and this is when we're going to see damage to the articular cartilage. Osteoarthritis is going to be when we get like wear and tear, okay? Over the years, these joints will start to wear down, and so it'll start to affect the bones, and this is an osteoarthritis. I'll talk about that in a moment here in the next slide. But how do we prevent, all right, arthritis? Or how can we keep it away from us as long as possible? Well, exercise is a great way. We talk about joint health, proper nutrition. So if you want to help maintain, all right, the joint health, you have to increase the flow of synovial fluid to the chondrocytes. Well, how do I do that? Movement. If you've ever gotten an email from me from my cell phone, at the end of my signature, I said, motion is life, never stop moving. Well, it means this. This is what it means. When you're moving, you're going to increase the flow of that synovial fluid across the articular cartilage, and that will absorb wastes from the chondrocytes. It also will help to diffuse nutrients into the chondrocytes. That's how they operate. That's the best way, right? Also, if you want to stabilize the joint and make it a stronger joint, strengthen your muscles. Exercising strengthens muscles, okay? Lifting weights or doing other weight-bearing types of activities will help to strengthen muscles, and that stabilizes the joint, okay? So here are the different types of arthritis, or the arthritides, okay? So when we talk about them, right, keep in mind, right, arthritis is going to be inflammatory. You'll get swelling there. And also, because of that inflammation, if you do not address inflammation early on, okay, if you do and you take care of it, usually no harm, no foul. But if you do not and it lingers there over time, you will get degeneration. You'll start to get tissue destruction. And when you get degeneration, then you'll have a disease process in the joints. So you will see swelling from the inflammation, and then you'll get pain and stiffness from the degeneration because we've damaged the articular cartilage. Eventually it goes away. What's left? Bones. Bones are highly innervated, right, through sensory nerves, so we get pain. So one type of arthritis you may have heard of is gouty arthritis. That comes from uric acid. Uric acid is going to be a byproduct that the cells will actually create normally in in healthy individuals, not to say that people that have gout are not healthy, all right, but they may have a difficulty getting rid of the uric acid. So what happens is they get increased levels of uric acid. The uric acid will precipitate out of a solution and turn into a crystal. So it goes from a liquid to a solid, and I shouldn't say it lives, but it'll reside inside the joint space there. So now you have these little crystals floating around and in that joint space. So where you should have no rough edges, now you have these crystals there, and it's very painful. And so we'll see this type of arthritis in older, middle-aged to older individuals, usually men more than women for whatever reason, okay? So they just have to stay hydrated because that will help to dilute the levels of uric acid. They should not be eating processed foods or specifically like lunch meat. For whatever reason, the lunch meat helps to increase the uric acid levels. Folks like that are also discouraged to drink sodas, right? Because that will cause dehydration. Osteoarthritis, that's the type of arthritis that happens in older individuals. This is the wear and tear arthritis. So we wear down that articular cartilage, and then it causes issues with the bones there. So you're going to see this type of arthritis occur in areas that have a lot of use, right, or in weight-bearing areas. So fingers, knuckles, hips, knees, and shoulders are going to be the most affected areas for osteoarthritis. And then we have our rheumatoid arthritis. All right, this is another type of arthritis that you'll see actually in a younger group of individuals, right? But most often we will see it in women. It is an autoimmune disorder. And so what will happen is the synovial membrane will become inflamed. When that occurs, all right, there's a special name for that. We call it a pannus, right? And so it's this inflamed synovial membrane, right, which can cause damage to the joint. And again, when we get the degenerative diseases occurring, right, then we start to get this type of arthritis, and it can go on and cause issues later on in life, all right, or at the time of diagnosis. All right, that is the end of chapter 9, articulations. So let's do this. Let us take a quick